Welcome to Mind Your Mental Health channel, a channel for mental health awareness, psychological health and well-being. This is our 33rd episode. In this episode, we are going to discuss about bipolar affective disorder. It is also called as bipolar disorder. It is one of the severe and enduring mental illness. There are different types of mental illness. We have been talking about that. And the past about 20 episodes, we have been talking about different mental illnesses which we come across in our practice, day-to-day practice. So, bipolar affective disorder or bipolar disorder is one such disorder. It can also belong to the psychotic disorder because some of the symptoms of bipolar disorder can go into the psychotic spectrum. Let's see in detail about that. So, it is a mood disorder. So, you need to understand the mood. We have done about 10 or 12 episodes on mind, different aspects of the mind. So if you need to understand in detail about mood, you need to probably look into those episodes. In fact, the episode on emotions, now I think it's episode 6, talks about mood. So if you look at the mind, if you want to understand the mind, there are 5 aspects or 5 systems in the mind. One is perception, other one is thought, third one is emotion, then we have behavior and primary mental functions. These are 5 different systems in the mind. Like if I have some problem in the brain, suppose I have a stroke, it belongs to nervous system. Suppose I have some other problem in the heart, there is a block in the heart, or there is a problem in the arteries or blood vessel, then it is a circulatory system. If I have some digestive problem, some stomach ache, or there is a problem in the stomach, I'm sick, I'm vomiting, I'm nauseous, this could be digestive system. Like that, in the mind we have a different system. One such aspect is called emotion. In the emotions, we have different emotional reactions and expressions. So it can be happiness, it can be sadness, it can be anxiety, anxious or fear. There are different play of emotions. And this emotion, when we have a sustained emotion, sustained emotional reaction or feeling, that is called as a mood. And when that is affected, it is called a mood disorder. There are different subtypes of disorders, different types of disorder under mood disorder. One such disorder is called bipolar affective disorder. As I said earlier, it denotes 2 poles. So the mood can be very high. When I say very high, I am talking about abnormally high. That is called mania. When it goes down, sadness, feeling depressed, low, very low, which goes into abnormal realm, then it is called depression. So the high mood mania and low mood depression is the 2 extremes of the mood. And when a person experiences these 2 extremes of the mood in different periods in their life, then it is called bipolar affective disorder. So we have understood something about mood, emotions, and we also talked about why it is called bipolar. So extremes of mood is called bipolar. So how common is this problem? And some of the research says about 1 in 200 suffer from bipolar affective disorder. Or some research puts the number as about 37 million people probably would be suffering from bipolar disorder in the world. And the lifetime prevalence, the chances of getting this in a lifetime is about 4 to 16 per 1,000. And onset is usually in younger age, young adult or late adolescent. So onset is anywhere between 15 to 19 years. That is a kind of a common onset of the illness. But it can also manifest in later age or younger age. We also seen bipolar affective disorder in children, now in 10 years old, 9 years old. And so it can also manifest in elder age, now 50s, 60s. But most commonly, around 30 years, anywhere between 20 years and 30 years is the commonest period when a person can develop bipolar affective disorder. So it is the mood disorder is mania or depression. So mania is more common in men. Now, some of the research says that mania is more commonly seen in men rather than women, whereas depression is more common in women. And women also can present with mixed presentation, where the simultaneously they can have both mania and depression, the high mood and low mood together. That is also more common we see in women. And there is another type of mood disorder which I'll discuss in detail a little later. It's called rapid cycling, which is also more common in women. So the mood swings are more rapid. And many a time in early part of this disorder it goes unnoticed. Number one, the person who is suffering from disorder may not realize that they suffer from the disorder. Even the relatives may not realize that it's a mental illness or it's a mental disorder which need treatment. They might think that okay, it is some kind of a deviation behavior, and they may not think it is a mental illness. So the research says that it takes nearly about 10 years to make a correct diagnosis. Why? I'll explain why. Why 10 years? So there is a disorder, one type of bipolar disorder called type 2 bipolar disorder, where you will have depression and we will have mania or hypomania. Hypomania is one grade lesser than mania. Sometimes it can go unnoticed. Sometimes people can tolerate that. So he's quite happy and they may not think it is abnormal. So you would have gone at abnormal level, but it will not be very, very abnormal. So that disorder takes time to diagnose, because when they are depressed, they suffer. They come to a doctor, or relatives might notice, and then they might go to the doctor for a depression. But they will miss the higher mood. They may not tell the doctor that I also suffer from higher mood. So that can lead to a diagnosis of depressive disorder than the bipolar disorder. Or sometimes because of pure lack of knowledge in the person or from friends and relatives, they may not spot the disorder. So sometimes patient can lack insight into the condition. They may not realize they suffer from mental illness. So they might go on with the same symptom for a longer period before they come to or get referred to a mental health services and made a proper diagnosis. So that is one of the reasons why we need to have more awareness about all the mental illnesses. Okay, so let me come to the signs and symptoms of bipolar disorder. As I said, it's a mood swing, abnormal mood states, extreme high, extreme low. So high we call it as mania, extremely high we call it as a mania, where they become very psychotic, they lose insight, they may not realize what is happening to them. That is a very high level of mania. So that is mania. Lesser level of mania is called hypomania. They may not have a very high risk or very extremely high mood, which could make them very aggressive. It could be lesser in degree, that is called hypomania. And we have depression. When the patient is in hypomania or mania, there are certain signs and symptoms we can see. So mood wise, they become very irritable, short-tempered, and they will have elated mood. Now they feel very high in their mood. They are extremely happy, pathologically happy or abnormally happy. And sometimes this mood can be very infective. The person who is talking to them feel that they are also feeling very cheerful. Now because the person with the mania or hypomania will be talking verbose, and they'll be joking, they'll use punning in their language or in their communication. So it will be so infective, their mood. So it could be elation, irritability, infective mood. That could be the presentation of mania or hypomania. When come to the mood in depression, it's a very low mood, sadness, lack of interest in any activities, lack of energy, they're feeling all the time tired. There is a number of other accompanying symptoms with the depression. We have done a separate episode on depression. If you have the time, you can visit that and have a look at that. So that is the confined to the mood, symptom confined to the mood, then the symptom can also manifest in behavior, because our behavior depends on our thinking, our perception, our emotions. If my emotions are high, if my mood is very high, my behavior will be very accordingly. If my mood is very high, I feel much elated, then it will reflect in my behavior. My behavior can become very hyperactive, what we call a psychomotor agitation or increased psychomotor activity. What it means is I'm very, very active, hyperactive, abnormally hyperactive. I can't stay in one place. I can't focus on one thing. I keep shifting, and my behavior will be depending on my mood and what thoughts I have related to the mood. If I think that I am the richest person in the world, I am a billionaire, and I will behave such way. I'll try to spend all my money thinking that I have lots of money with me. Or I can be very disinhibited. So there is something in us now which controls us. Now our higher function, our mind tells us, no, this is not right way to behave. Control yourself. That inhibition is gone in a mania. They will be completely disinhibited. That can manifest in the way they behave, over familiarity. They can go and talk to any stranger like a friend. They can shake hand, they can hug them, they can say, oh, I like you, anything they can say. It's totally disinhibited behavior. It goes to the extreme. They can also become very inappropriately dressed, or they can make sexual advances. So that itself is a risk. So disinhibited behavior ranging from mild to very severe and to psychotic level. And they can also develop grandiose delusion. I'll come to that little later about the delusion. When they have the delusion, they might believe very extremely abnormally. They think that I am the richest person, or they may even think I am the king of this country, or I am an executive of that company, and they can go into the company office and behave that I am the executive. Everybody should listen to me. So that is a behavior they develop secondary to delusion. It could be anything. It could be religious, or delusion that I am the God. I can say that I can make rain come anytime, or I can say I can change this whole world. So they will act accordingly. That can lead to problem for them. And in extreme mania and extreme agitation, they can also become very aggressive, because they can't take a no for an answer. And if somebody contradicts them, somebody challenges them, they become very aggressive. They can become very aggressive because they believe they are that person. So that is a behavior: aggressive behavior, hyperactive behavior, disinhibited behavior, grandiose behavior. These are the behavioral manifestations of mania. When they come to depression, when they go into the depressive spell, they become very low in their mood. They become sad. They become tearful. They lose interest in everything. Their activity comes down. They are very withdrawn. Very talkative person, friendly person becomes very withdrawn. They shrink into a shell. So that is the depressive behavior. So the bipolar can express in behavior depending on the mood extreme they have, mania and depression. Then speech. Speech is our expressions of mind. So in mania, they become over talkative. There is a pressure of speech. They tend to speak very, very rapidly, and sometimes it's so rapid speech might become irrelevant. So they become over talkative, and they have a flight of ideas. What I mean by flight of ideas is, when we talk, we have ideas which comes in a sequence. Now B follows A, C follows B, D follows C. There is a sequence in that whole concept. I'm talking about bipolar. There is a sequence. The ideas flow through one after other, meaningful way. In a mania or hypomania patient, the thought is so pressure. They get so many thoughts. Now, number of thoughts bombarding them. They keep shifting from one idea to other idea. So, or they go into a flight of ideas. The ideas are flying out. They say, I am the chief of this country, I am the chief minister, or I am the prime minister of this country, and they fly on to something else. No, I met the ambassador of this country, and I'm going to talk to them. I'm going to take over that country. Or it can be anything. So it's a flight of ideas. And sometimes It can also become circumstantial. They start off with one idea, then go around, beat around the bush, and then come back to the same idea. So flight of ideas, pressure of speech, and over-talkativeness, disinhibition, over-familiarity. If they go to a marketplace, if they go to high street, they go and talk to anybody. They will not have inhibition. They will become very over-familiar with people, and they will cross the boundaries, personal boundaries. That can lead them into problem. So that is the mania speech. And in depression, slow speech. Speech becomes very retarded, very slow. Ideas are lesser. They may not get ideas, so they may not talk fluently. If you ask a question, they'll take long time. They can also be preoccupied with their mood, low mood, sadness, or problems in life. So the preoccupation leads to slow ideas lead to slow speech. And poverty of thought. They may not have number of thoughts coming into them. Their talk will be very pessimistic. The speech can be very hopeless or guilt-laden speech. These are all speech in depression. Then we have thought. In thought, patients with mania will have an inflated self-esteem. Now their self-esteem is so high, they feel that nobody can question me. I am the best person in the world. And they will act accordingly. And they can also have grandiose delusions. When we say delusion, delusions are unshakable false belief. So it is unshakable, it is false. So I think I am the millionaire, or I own a number of companies. When I don't have that kind of a reality, then that belief is a false belief. But it's unshakable. Somebody comes and proves me, or tries to give me reason, evidence to say that you are not owning the companies. You are not that rich person what you are thinking. But I will not listen to them. I'll say you're wrong, I am right. That's where I lack insight. So that is a grandiose delusion. The delusion, when it becomes grandiose, then it becomes grandiose delusion. It's called grandiose delusion. If it is a persecution, we call it as a persecuted delusion. Mostly in mania, we get grandiose delusion. We might get persecuted delusions also. That is secondary to grandiose delusion. Because I am very rich, people are against me. Because I'm the king of this country, people are trying to persecute me. They are jealous of me. That is a secondary delusion that have. But primarily they'll have grandiose delusions. In depression, thought level is tuned to the depressive mood. They have low self-esteem. They feel they are not good for anything. They can't do anything. They lack confidence. The excellent professional who is very good in this profession might suddenly develop the thought that I'm not good at it. I can't continue that. I can't do that. They might not go to the work. So poverty of thought. So thoughts will be sparse. They will not get any ideas. So that's why the speech becomes very retarded. And they can have a delusion related to the mood. Now they may have a delusion of guilt, delusion of blame. Now they might feel that I have done something wrong in that particular time. That's why I'm getting punished. That will go to the delusion level. So these are all thought manifestations of a depressive patient in a bipolar condition. And perception. Now, when you talk about perception in mental illnesses, we are talking about hallucinations. Hallucination is a false perception. Now, in absence of a stimuli. So hallucination is a false perception in absence of a stimuli. There is no stimuli, there is nobody talking, there is no sound here, but still I hear voices, somebody talking to me, telling them, Soundaraja, what you are doing is wrong. Soundaraja, you're so-and-so. So why are you here? Walk out. So those kind of perception without any real stimuli is called hallucination. Hallucination not that common in bipolar disorder. But it can happen. Secondary to psychotic symptoms they develop. When I say psychotic, I'm talking about delusions. So they can hear mood-related hallucination. Suppose my delusion is I am the richest person. I own several companies. I'm a billionaire. The hallucination will be like the voices will tell me that you are the rich person, or would you like to buy that expensive car, or would you like to buy a jet, aeroplane? So that kind of hallucination can come. In depressives, hallucination can be punishing. You are the sinner. You are a guilty person. You are not worth living. you'll have to do something about it. So that kind of a hallucination can come, but they are not very common. It can come when they attain a psychotic proportion. Both in depression and mania, sleep can be deprived. They can have very severe insomnia or lack of sleep. In a manic patient, they feel so energetic, so full of energy, they feel they don't need sleep. And they will go without sleep for days, still they can be very energetic without any tiredness. That is due to the mania. Everything goes up. Action, thoughts, everything is rapid. So this is, everything is rapid. So the activity is also rapid. So energy is so much, they don't get tired. So that is a different kind of sleep deprivation in a bipolar patient. Another one is depression related sleep problem. They feel they can't sleep and they go to bed, they might get a sleep, they might get up early in the morning, what we call early morning awakening. So they get up around 2 o'clock, 3 o'clock in the morning, they feel very gloomy, dull, very sad, they feel like crying. That is a different kind of a sleep problem. Both can occur in bipolar disorder depending on the stage in which they are. And then another important parameters we look into when we assess a patient when they have a mental disorder, especially psychotic disorder, is insight. Insight is awareness about their illness, their mental illness. In a psychotic individual, they lose insight. What I mean is they think they are all right. They don't realize they suffer from a mental illness. All their behavior and actions are related to their mental illness. They think what I am doing is right and I don't suffer from any mental illness and they are wrong. So that is the kind of a expression they will have. So in extreme cases of mania and depression, when depression becomes psychotic level, they lose insight. If you go and talk to them, if you go and tell them probably you are suffering from mental illness, some kind of mental illness, it could be bipolar, why don't you come to the doctor? I will take you to the doctor. Suppose a friend or a family member says, then he will say, no, I am not suffering from mental illness and I am perfectly all right. I do own so many companies. I am the richest person in this world. I think something wrong with you. You go and see a mental health professional, but I don't need to come. That is the kind of a response they might give you. So they lack complete lack of insight. That what happens is because they lack insight, they can indulge in a lot of activities that could be very risk to them, risk to others, risk to properties, or it can delay the treatment, or it can delay the early assessment and treatment. That can lead to other complications. So these are all some of the signs and symptoms of bipolar affective disorder. Next question is there different types? There are a number of types of bipolar. I will try to give you 3 types, which is more commonly used in our clinical parlor. So there is type 1, type 2 and rapid cycling. So I'll give you briefly, I'll tell you what it is. Type 1 is where you have a mania, very clear-cut mania, and it could be followed by depression. So that is type 1. In type 2, they will have depression and mania, but not to the high level of mania. They might have milder form of mania or hypomania, mild hypomania, which might go unnoticed. So type 1 is severe mania, depression, alternating, that is type 1. Type 2 is depression, predominantly depression, more of a depression, and some hypomania, milder form of mania, which goes unnoticed. So this is type 2. Rapid cycling is they get mania and depression as a cycle, 4 attacks in a year. In a 12 months period, if the patient has experienced mania and depression, which alternates, I go into manic phase and then I crash down to depressive phase 4 times in a year, then it is called rapid cycling. So there are a number of other types. Now there are type 3, 4, but this is what we clinically use these typings. Okay, so we have learned what is bipolar and what is mood, little bit, and I talked about the signs and symptoms. And now the next question, also types. Next question is, why do we have to treat them? Now, if he is happy, if he thinks he is the richest person, And he is so happy. I never seen him so happy. Is he enjoying life? Why should I treat him? It's a good question. We can leave like that. Let him enjoy. But there are risks and complications. That's why we need to treat them. So risks are, the risk of self-harm or suicide is much higher. Especially the attempted suicide and suicide is much higher in bipolar disorder, especially when they go into depressive phase of the illness. So risk of suicide is much higher compared to other disorders. Now, some of the research say that in bipolar disorder, at least 17% of persons suffering from bipolar could attempt suicide in their course of the illness. And another kind of a worrying statistics or research finding is 0.4% of bipolar disorder do complete suicide. That is, they die by suicide. That is another risk. That is the reason why we need to identify them earlier and treat them effectively. Other than risk to self in the form of suicide or attempted suicide, the risk to others is also there, because in height of mania, they can become very aggressive, because they feel that whole world need to agree with them. If they don't agree, they become very aggressive. So that is one of the risks to others. So they can be verbally or physically aggressive to anybody who is trying to challenge them. It can happen among the friends and relatives, or it can happen in anywhere in the public space. So that leads to other kind of risks. And another kind of risk in bipolar patient is vulnerability. They become very vulnerable because they feel they are very rich, or they can feel they have magical powers, or they have godly powers, or whatever abnormal belief they have. They act on it. People can utilize that. You can use that to exploit them. So suppose I think I am the richest person in the world. People can approach and then play with my thought. Yes, I know you're the rich person. I don't have money. I have lots of problem in life. Can you give some money? He'll readily give money. Some of these patients can donate indiscriminately to charities. They overspend. That can lead them to severe financial problem. They can bankrupt them. They can completely wipe out their bank balance in a day or two if the mania is very high. So those are all the risks associated with bipolar, depending on which phase they are. If they are depressed phase, suicidal risk. If they are in height of mania, risk to others, aggression, leading on to many other problems related to aggression. It could be DPH, leading on to police involvement. Or it could be overspending, blowing up your bank balance. So these are all some of the risks. And other complications are like, so when they become very high in their mood, they become very disinhibited. That can lead to indiscriminate sexual activity. They can become hypersexual, then it can lead to indiscriminate sexual activity. That can lead to lots of other complications. It can lead to marital breakdown. It can lead to police involvement. There are so many things that can happen. So we talked about number of aspects of the bipolar disorder. So next is, you might ask me, why do people develop this? Why? What causes this? In psychiatry, in mental illnesses or mental health, we always talk about biopsychosocial model. Bio means bodily changes. Psycho means psychological changes. Social means societal changes. What happens around him? His education, his job, financial status, social status, everything counts into the causes of mental illness. So as far as bipolar affective disorder is concerned, let's take up first bodily changes, or what causes bodily reasons. Now, most important thing is changes in the neurochemicals. Our brain has lots of neurochemicals, which is very basic for our day-to-day activities. Thinking, everything depends on these neurochemicals. I have done a separate episode on that. So you can go into the playlist and then look up. So that will give you mind and brain. The title is Mind and the Brain, where I explain detail about neurochemistry and all those things. So neurotransmitters are chemicals. When the balance in these chemicals change, they become very low or high, that can lead to mental illnesses. In bipolar affective disorder, The neurochemicals by name dopamine, noradrenaline or serotonin. These are the chemicals involved. When they changes, the balance goes up and down, then that can cause bipolar disorder. Other biological causes, genes. Bipolar disorder can be heritable. It can run in families. When I say run in families, don't be alarmed that if one person the father is given a diagnosis of bipolar, not necessarily son should develop that. It depends on other factors also. What they inherit is a propensity to develop bipolar disorder. Not that immediately they should develop bipolar disorder. It depends on other factors. But having said that, let us look at the risks of inheritance. What are the possibilities of inheritance if a family member has a bipolar disorder? What research says is, if one first degree relative of a person has a diagnosis of bipolar disorder. Let's understand this clearly. When I say first degree, I'm talking about my father, a mother, brother. So this is a first degree relative. If one of the first degree relative, suppose my father has a bipolar disorder, the chances of me developing that disorder is about 7 to 10% risk. So let's put it as 10%. So if my father has a bipolar disorder, as a son, I have a propensity to develop this about 10%. Rest 90% depends on many other factors. My biological factors, my neurotransmitters, and my psychology makeup, my social support, everything counts. So next is, if both my parents have bipolar disorder, then my chances of developing bipolar disorder increases to 28%. So rest of it is other factors. So that's how the risk of inheritance is calculated. Next is psychological reasons as a cause for this disorder. There are a number of psychological reasons. I'll give you some of the reasons. One is childhood experiences or trauma. When a child goes through very severe traumatic experience in childhood, it could be physical abuse, sexual abuse, neglect, any kind of these traumatic experiences can lead to a bipolar disorder in later life. When I say that, so you need to be aware that we are talking about the chances of developing bipolar disorder, not that they will develop bipolar disorder. It depends on many other factors. Let's say the child has gone through severe trauma and there is a family history of bipolar disorder, and there are a few other causes which I'm going to enumerate now, add-ons to this child, then child might develop bipolar disorder. That's how we need to look at it. So when I say one cause, doesn't mean that that particular cause immediately produces or precipitates a bipolar disorder. Next is emotional dysregulation. All of us have our emotions, changing emotions. Now it fluctuates in the day-to-day life. Now it goes high and down depending on the circumstances. We immediately recover. I shouldn't say recover also. Immediately we'll come back to different emotions. So emotions keeps changing depending on the situation within the normal limits. Sometimes these changes can be in extreme. Again, within the normal limit, it could be called as dysregulation. So I fly into anger, I fly into dysthymic or pessimistic mood or low mood, and I fly into happy mood. So this dysregulation can be indicative that patient can or may develop bipolar in the future. But again, you need to take it with a caution, because I'm not talking about one particular aspect leading on to bipolar. We are talking about a number of reasons acting as a cause. Then sleep deprivation. It is very important. Now, sleep problem is one of the major problem in. Next is sleep deprivation. It is a very important aspect of bipolar disorder. Both in depression and mania, sleep can be deprived. They can have very severe insomnia or lack of sleep. In a manic patient, they feel so energetic, so full of energy, they feel they don't need sleep. And they will go without sleep for days, still they can be very energetic without any tiredness. Next important cause for developing a bipolar disorder is sleep deprivation. Extreme form of sleep deprivation. I'm not talking about a bipolar patient having a sleep disturbance, that is a symptom of a disorder. I'm talking about a normal individual consistently having a sleep deprivation due to several reasons. It could be work related, it could be your social media, entertainment, but consistently you're ignoring the need for sleep, or you're overworking yourself, pushing yourself to the edge. That can also precipitate a bipolar disorder, provided you have other factors also. Sleep deprivation alone not immediately can lead to bipolar disorder. Sleep deprivation itself is a big topic. It can lead to many other problems. We will do an episode on sleep. Then I will discuss about sleep-related problem. But for this episode, for bipolar disorder, if you are consistently depriving sleep over a period of time and you have other factors which could contribute to bipolar, then there is high chances of developing bipolar. Next is basic personality. Now, how you are, what is your psychological makeup, what is your resilience level, what are your coping skills, that can also contribute to the development of bipolar disorder. Next is social cause. Now, I said biopsychosocial, social cause. Social cause is very stressful life and social isolation. It can lead to any kind of mental illness. Now, it can lead to paranoid disorder, it can be psychotic disorder, it can lead to anxiety disorder, it can lead to depressive disorder, it can also lead to bipolar disorder. And impaired family relationship. It could be between partners, husband and wife, or parental. It could be anything. Sustained impaired relationship can also contribute to the development of bipolar disorder. It can also contribute to relapses also. We'll talk about it a little later. Okay, next question will be, what is course and prognosis? What happens to this disorder? How does it run over a period of time, in a decade or two? If I'm diagnosed with bipolar disorder, what will happen to me, doctor? How I'm going to be in the next 10 years, 5 years, 15 years? What is the prognosis of? Will I get completely all right? Or will I continue like this? So these are the questions answered by a title called Cause and Prognosis. Okay, let's see. We need to understand bipolar disorder is a severe and enduring mental illness. That means it's going to run a longer course. It's not going to end in one treatment, one course of treatment. It is not like I go to a doctor with a chest infection, I have some common cold and then develop chest infection, and the GP gives me antibiotic and then everything clears. That is one-time treatment, that's clear completely. So bipolar disorder is not like that. It is like continuing, enduring mental illness. Suppose I go to GP, he makes a diagnosis of diabetes, then it is going to be a continuing illness. So diabetes can be completely controlled. 100% it can be controlled with a proper treatment and adequate treatment and continuation of treatment. Similarly, bipolar can also be completely controlled and they can lead a 100% normal life. So the course can be one mania, alternating with depression, then coming back to normal, continuing normal for some time, again having depression, and then coming back to normal, then sometime later going on to mania. That is how. The gap in between these two episodes varies with people. Depending on the severity of the illness, it varies. It could be once in a year, once in 2 years, or it could be once a month or once a week. So it varies now. So ups and downs varies. But initial days, when you make a early diagnosis at the early onset of the illness and treat them, but diagnose and treat them effectively, then the gap between the attacks remains longer. They can remain completely normal, 100% normal. They can lead a normal family life. They can hold a job, whatever kind of a job it is. They can lead a very normal life, productive life in between the attacks, and provided they take treatment and they follow all the support they get and they follow all the kind of advice you get to prevent any relapse of the illness. That is very important. Treatment adherence is very important. It can lead to a normal life. And if not treated adequately, if the patient is not complying with the treatment regularly, medication adherence is not that good, then it runs a chronic course. So suppose there is a repeated relapse, repeatedly patient discontinues medication, develops illness, then that can lead to shortening of normal period. The normal period is 1 year. when I was diagnosed. I get only once in a year an attack, and early diagnosis and early intervention immediately settles things. So I might be probably having symptoms for a few days or a few weeks and then completely come back to normal. So 1 year of very normal life, or it could be even 2 years. But I attended the treatment center first time I had the problem, and they prescribed medication, they gave me all the input, they explained me about everything. They said it's very important to continue medication, but over a period I thought, okay, I'm all right, why should I take medication? So let me stop it. I stop it, then I get a relapse. So if I do it repeatedly, I used to get once in 2 years relapse, that will become once a year, once in 6 months, once in 3 months also. So important aspect is treatment. How well we are treated and how well I engage with the treatment is very important. Okay, so treatment, early diagnosis and treatment is key factor for managing bipolar affective disorder. So you can understand from this that it is very important that patient is diagnosed early and treated adequately, and treatment continued for a period of time. So next question naturally leads on to what are the treatments available for this disorder. Treatments can be biological treatment, that means medication. Now something you give to the body and then that changes the symptom. So medication, and it could be psychological treatment. Number of psychological therapies are available, and it could be social manipulation or social support or social input. All these three matters in treating bipolar affective disorder. So let's take up the psychiatric management. So what do we do? Suppose I get a patient today, extremely manic. Now, and also there are a lot of risk there. And but he has a good family support. Actually, the relatives have brought him here. So this patient I'm seeing, I'll have to decide whether I can treat this patient as an outpatient, give a medication, ask the family to manage, now support him, and if that is the level of kind of a manageable level, I will take that route. I would say that you have this problem and he has a partial insight, he also realizes he has a problem and is willing to take the medication, and he is willing to engage with the services. He is happy to come back and see me. And also he thanks me that, okay, doctor, you made the diagnosis. Now I know why I'm behaving like this. Okay, I'll do whatever you want me to do. Okay, I'll say continue the medication. Never stop the medication. If you ever have an idea about stopping medication, please contact me or the team or your GP so that we can manage you. We can see what can be done. Or if there is a problem with the medication, we could look into the medication, we can change the medication, but please don't stop the medication without telling us. So that is the advice we give. So if he is okay with that, outpatient treatment. I see him in a week's time, 2 weeks' time, 1 month, then he settles down, there is no need for admission. So we managed everything. Again, depends on the risk. If the risks are very high, if I think that by sending him home, I'm not going to manage the risk, then I would say you need to be admitted. So next scene or next scenario is, here is a patient highly manic or highly depressed and has suicidal ideas as a depressed patient, or he spent half of his bank balance. If he's going to leave him in the community, he's going to blow up all his money, and he's also been very aggressive on the high street, and there are police involvement. Then I would say that he needs admission because we can't send him home. We can't manage his risk. He's going to hurt himself or damage himself or hurt others, or even property damage. They can bash up things. They can break up things. So that is a risk. So I say you need to be admitted. I'll explain to him what he's going through, and I'll tell him this is the reason why we want to admit you. And he says, doctor, no, I can't get admitted because I have a dog at home. I can't leave. Then I'll bring in a social support. I'll say we will arrange that. We'll ask the social services to support you in such a way that your dog is looked after. Now we will support you on that. Please get admitted. Okay, he says, okay, if you are that's okay, then I'll get admitted. So he comes in what we call as a voluntary admission. He voluntarily comes into the hospital and gets treated. Still he might have delusion, but he says, okay, I'll come because you are telling me, asking me, and you are explaining, okay, I'll come, doctor. So that is one scenario. Next scenario is, he says, no, doctor, you are wrong. No, I don't think you are a psychiatrist. Now I know everything. And I'm also a doctor. So I'm a psychiatrist by myself. Now, so you don't believe me? You're laughing at me? No, 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 no. You're wrong. I think you're a fake doctor. So what you're asking me is give up all my companies, all my activities. I need to go to so many charity places and the things. I'm a celebrity, and you want me to put me in hospital? No way I can do that. I'm going to go, and then also have a couple of people. I need to challenge them. They told me something which I need to clarify. I need to really manage them. Okay, so this is the situation. In this situation, I need to think that I know patient has a right to refuse, but what I'm looking at is capacity. Here, patient completely lacks capacity. He doesn't realize he suffers from mental illness. He doesn't realize his mental illness, whatever behavior he is having, is harmful to him, or it can be harmful to others also. Either is depression harmful to himself, mania harmful to others. Now he can break up things. He is completely unaware of all those things. He is completely unaware of consequences of his behavior, which is due to his mental illness. Then he lacks insight. He lacks capacity, and there are strong indication he suffers from mental illness. The degree of mental illness is very high. Nature of mental illness is also very severe, because it's severe and enduring mental illness. So nature, degree, risks, and he lacks capacity, and he refuses medication. I also offer him, okay, we will manage you with a crisis team. We'll ask people to come and see you. Will you be okay with that? He says, no, nobody should come to my house. No, I'm not mentally ill. No mental health professional should ever contact me. Then I decide that he needs to come into the hospital against his wishes. This is what you call involuntary admission or compulsory admission. There are excellent provisions in the Mental Health Act to manage this situation. I'll be doing a separate episode on Mental Health Act, and it's a kind of a practice. So we will discuss in detail about that. But currently, in this kind of a patient refuses admission, risk, lacks insight, lacks capacity, then we go for a compulsory admission. That means he will be admitted against his wishes, against his will, for his betterment, for managing the risk. Okay, so that is what we need to decide when I see a patient first time. So once we decide it's outpatient treatment or inpatient, whatever it is, I need to, next step is medication, because next step in the management is medication. Then only all the other things come. So I need to decide what medication I need to prescribe, and also need to decide about maintenance treatment. So treatment wise, psychiatric assessment and the management that leads to acute treatment, that is admission, outpatient, admission, under admission, voluntary or involuntary or compulsory, and outpatient treatment. Then the third aspect of treatment of bipolar is maintenance treatment. How we are going to maintain this stability, how we are going to maintain him stable for years and years so that he can lead a productive life. Okay, that brings us on to next aspect of the treatment, that is medication. So once I decide what kind of a treatment we are going to give, like when I say treatment, I'm talking about whether admission or outpatient, then I think about medication. There are a number of medications available to treat bipolar affective disorder. They can be grouped into antipsychotic medication, anti-manic medication, or mood stabilizers. So these are all some of the medications available. We also use sedatives sometimes. As I said, sleep is the predominant problem. So we can sometimes use sedative or hypnotics for sleep, and also for calming down the patient. Okay, if the patient is highly aggressive, sometimes they become very violent also, then we need to resort to some of the sedatives to calm them down. And so there are two categories of medication. One is antipsychotic, other one is mood stabilizer or anti-manic, you can say. So antipsychotics usually used when the disturbance is very high, very disturbing and damaging and high risk, then we need to resort to, and it is coming from the delusions, that is psychosis. So once the patient has the delusions, then it becomes a psychotic illness. So then we need to use antipsychotic medication. And there are mood stabilizers. These mood stabilizers use to prevent further relapses. So initially, if the disturbance is very high, we might use antipsychotics and then switch over to mood stabilizers, which can be kind of prescribed for a number of years now, over a period of time. So these are all some of the medication which you use. And if I admit a patient in a bipolar patient with severe depression, then we use antidepressants. Sometimes we can enhance the effect of the antidepressant adding small doses of antipsychotic also. So there are different combination, different permutation. But how we select a medication, there are different parameters used. One is symptomatology, how severe the problem, how risky is the problem, how we need containing. This is one parameter. Next is, what is the best medication, evidence available in this for this particular disorder? All the research done, all the input we have from different sources, guidelines. What are the best medication? Then we rank it. So this is the first one we'll try. I select the first one and I look at the side effect of the first one. The first selected is excellent medication but induces weight gain. Then I need to look at the patient. Oh, patient is already obese. Then will that be a good choice? No. Or it can also induce metabolic condition, like it can also induce diabetes, then I will avoid. Then I go for the next medication which does not have that side effect. So I'm giving a very kind of a sketchy idea about how we do that. It's more deeper, more analyzed also. So the medication we select depends on the symptom he has and the physical illness or physical health, and what kind of medication is helpful in this situation. Suppose sedative medication to calm him down, which also helps his mania. Those kind of thoughts will go into a psychiatrist's mind or person who prescribes mind to decide about medication. Once we decide, we explain about the medication, we tell them he has to take it regularly. So that is about the medication or biological aspect of the treatment. Very in extreme cases of depression, we can also use electroconvulsive therapy. It's known as ECT or popularly known as a shock treatment. It is a very good treatment provided it's given to appropriately selected indicated patients. So it could be life-saving sometime. Now in extreme depression with extreme suicidal ideas, all the other medication not effective and still patient has, and we are really struggling to manage this risk, then I might think, okay, let's go for ECT. Or depressive stupor, I discussed about in my episode on depression. Depressive stupor, where patient doesn't talk, doesn't do anything, just lies down and doesn't eat, doesn't take any fluids. So there is a risk of dehydration, the risk of patient dying. Then I might resort to ECT. So ECT has a place in treatment. So that is biological. Then we have few other treatment modalities which probably we'll discuss when I talk about treatment itself. Now I will do an episode that will be kind of about another 20-30 episodes away. So that episode I'll talk about what are the treatment available in mental health. Okay, so that is the biological aspect of the treatment. The psychological aspect, there are a number of therapies available, hundreds of therapies available, but there is also research gone into these therapies. Now which therapy is good for which disorder? So for a bipolar affective disorder, CBT is very good, cognitive behavior therapy. CBT can be given for many number of diagnoses, but bipolar is also one of the diagnoses which CBT is very effective. There is a research evidence to say that it is effective. And psychoeducation is another very important aspect, because patient need to know about his illness. He need to realize that what I am going through is a mental disorder and it needs treatment, it needs continuous treatment. To drive home that idea, we need to educate him, not only him, the relatives, because I might be taking the medication, willingly take the medication. My relatives, my partner or my son or my daughter say, oh, Daddy, why you are taking this medication for so long? So you have been taking for 4 years. Why don't you stop it? Because she may not know the consequence of that. Now I might stop it. So that's why the relatives, the close relatives, the family should know what diagnosis and what are the treatment. And then the CBT can also tuned in such a way, it promotes medication adherence, explains about the disorder. So it supports the medication compliance. Okay. And another aspect of psychological aspect is monitoring the mood by themselves. Now patient can have a mood diary and they can chart the diary, the changes in the mood. That helps the professionals to understand how the mood changes. So keeping a mood diary, it is available. You can Google it, people can get it. So mood diary is another aspect. Psychologically, it helps to manage the disorder. Then coping strategies. Now, stress management. Now, all of us goes through stress. Now, there is nothing, there is not a single person in the world who doesn't have any stress all through their life. Now, we all go through stress. We come out of it. We have coping strategies. Now, we develop our own coping strategies. Some could be pathological or abnormal. Some could be very good, very effective. So, whoever uses the effective method, they get well sooner, or they are able to manage. So we need to talk about stress management and coping strategies, how to use effective and positive coping strategies to the cope with the day-to-day life. Because one of the indicators for relapse of bipolar disorder is stress. Life events can trigger a mania or depression. So that's why we need to talk about coping strategies. Okay, now next couple of topics is about carers and family and the patient themselves. Okay, so if a carer is watching this video, I need to tell them about the bipolar disorder. Few points about what they need to do. So families and carers, please learn about the disorder. There are a number of material available in social media, on net, but be careful, cautious to select the authentic and proper one. As for of course, we are doing that. I mean, our channel is talking about it, and it is a channel run by a professional. You get the information from the professional. Other than that, you have a mind.org. I mean, some of you might know it. It's an excellent website where it gives you. It's a charitable organization. Gives you all the information you need about the disorder. So look for or learn from your team. I mean, suppose your partner is suffering from bipolar, treated by mental health team, some of the teams do conduct awareness program. They do conduct bipolar education groups for patient and the relatives. Please do attend, learn about the mental disorder, especially bipolar. And always promote early intervention. If you think that a patient might be suffering, so talk to the person, talk to the GP, and try to support the person, go for an assessment. So promote early intervention by professionals and mental health services. That is another important aspect you can do. And support the medication compliance. Now, suppose patient has kind of ambivalent about medication, talk to them, or take them to the GP. GP could explain to them, or take them to the mental health services which is treating them. They will be able to explain to them. So support them in maintaining the medication, and avoid critical comments. Now, don't criticize them. So you need to understand some of the behavior is because of the mental illness, the disorder what they have. So don't blame them. Don't recollect the past and tell them. No, suppose there is an argument. You might impulsively recollect something in the past which could have been related to the mental illness, but don't blame the patient for that. So those things, critical command, challenges, you need to be careful. So because you need to be careful, because does it touch upon the mental illness what he had, behavior related to mental illness? So you need to be a little more careful about those things. So, and that is another important factor. And as I said, understand the behavior is due to the mental disorder. When the mental disorder treated, that behavior comes down. And it could be sometime when the disorder runs chronic in a person, it could be difficult for the families and carers to cope with that. I do understand that. It could be challenging, difficult. That's why you need to be aware that you could be overwhelmed. You need to seek support. Every mental health services will have a support system for carers. Now it's called carer assessment and carer support. Now they will have to offer you that. So if you have that kind of a stress or overwhelmed, you need somebody to support you, somebody to talk to you. It could be just talking to someone or attending a group, now support group, now carer support group. That itself is relieving for you. So approach them. Now get the help if you need them. Now don't keep it to yourself. Don't bottle up, because the patient needs you. So that's why, for your sake and for the patient's sake, you need to look after yourself. Okay. So next is about the person who has been diagnosed with a bipolar disorder. Message for a person. If you are a person who is watching this, already has a diagnosis, already being treated by a mental professional, then few points for you. Of course, they would have explained to all these things to you, but I'm just adding or recollecting or reinforcing what I already told you. Learn about the disorder. Again, same thing. As I told your carers and relatives, you should learn about the disorder. You need to understand what is happening to you so that you can monitor your mood yourself. You can know what are the early symptoms of relapse. Then you can go to the doctor. Approach them. This is what happening. And good sleep habit is very important. I know social media is really encouraging on our sleep. Now normal sleep has gone to 12 o'clock or 1 o'clock because we're looking at the mobile all the time. So that is a stimulant. So you need to be very careful about your sleep. Discuss with your team about sleep hygiene, sleep habits, and try to preserve your sleep. Normal aged adult needs about 8 hours of sleep in a day. So night sleep is the best sleep. That is the time everything goes on in your mind and the body maintains this. That is a maintenance workshop we do. Now every night I park my body and go to sleep in a maintenance workshop. 8 hours I leave my body to that workshop. It changes, it tinkers, it changes, maintains my body and mind. So that's why sleep is very important. So sleep is very important. See to that you get a good sleep. And healthy diet and exercise is important. You might say, you never mentioned in the cause about diet and exercise. Why are you telling me now? Healthy body is very important for healthy mind. They are dependent on each other. I talked about psychosomatic disorder and an episode, look into that. So healthy body is very important because some of the unhealthy things happening in the body can precipitate mental illness. Well, suppose hormonal balances, all those things. So you need to be very aware of your health, and you need to have a proper diet, proper exercise. Because some of the medication can induce weight gain. Some of the medication can increase your cholesterol level. You need to be careful. You need to be monitoring yourself. That means you need to have a healthy lifestyle. No smoking, diet, good diet, healthy diet, balanced diet, regular exercise, physical activity. These are 3 simple things you need to do. And always learn about your early signs of relapses. Now, your professional, your mental health worker working with you should be able to give you that information. What are the earliest signs which say that you are going back to the problem again, relapse? It could be sleep. The past 2 days, you have gone to sleep as usual, but you're not sleeping well. That could be the onset of the next relapse. So you need to be. Our life situation is very stressful. Everybody is kind of arguing with me, challenging with me. I don't know what to do. I'm stressed. That could be early. Now reacting to that now could lead to relapse. So all those things you need to know. Then if you have any of those early symptoms, go and talk to them. Just minor changes in the medication or additional medication for a short period or just counseling or some kind of support will solve the problem. That's why you need to be aware of that. So the last one is have a crisis plan. If you are suffering from bipolar disorder, your team should be able to give you a crisis plan. What it means is, if you develop a relapse, suppose I'm suffering from bipolar disorder and suddenly I have a relapse, suddenly I develop mania. Next day I feel, no, I'm working somewhere else. I am working in Prime Minister's office, PMO. So I need to go to Prime Minister's office today. I think about it, I don't act on it. Next day, the thought becomes a delusional level and it's become very unshakable. Then I say, I will not go to the work today. I go to the sick. In that kind of situation, if your crisis is there in your mental health, then you need to have a plan. So that plan will tell you, talk to the crisis team. They might give you a direct number for the crisis team, or they might also give you points for your carers or relatives to act on. So you need to have some plan when the crisis happens suddenly or when the crisis happens. So you need to have that plan. You can ask for that plan and you can note it down. And you can also inform your close family member or carer. That way you're prepared for any eventualities to manage this. The ultimate aim is keep the person well long period of time. Now I said in between the attacks, in between 2 mood swings, they can lead a normal life. We want to maintain that normal life for years and years. It could be possible with effective treatment and compliance with treatment and support from the services, the family, friends and relatives. On that note, I will end this talk on bipolar. In the next week, we will discuss about another group of disorder. Now, we have discussed about number of disorders. I talked about anxiety, depression, and so many other disorders so far. Now we have come to 33rd episode. The 34th episode, I will talk about personality disorders. Personality disorders are a group of disorder, which is also very commonly we see in our day-to-day practice. Now, many of our patients would have a diagnosis of personality disorder. Let us learn about that in our next episode. Thank you very much for being with us, and do come back and visit us, and do go to our playlist and then look at number of disorders which I have talked about, which gives you an idea about what is that particular disorder is. And it is always good to learn about these disorders. Do visit them. Do subscribe to our channel. Do share with your friends and relatives and even your colleagues, so that more people get to know about mental illness, how to manage them. Thank you very much. See you again in my next episode. Bye.